Hey everyone, it's Rona again, PGY2 at Walter Reed, here for another shelf review video. Would love to continue hearing your feedback, and like before, this is meant to be more interactive, so I'll be stopping multiple times throughout the video. You can feel free to pause and think about the responses before you proceed. So starting off with a case and a question that you might see throughout your question banks, it's a 65-year-old male, history of hypertension, hyperlipidemia, had an MI in the past, and active alcohol use who's presenting with abdominal distension, and you notice that he has a SAG gradient of 1.5 and an acidic total protein of 2.8. Don't worry if you haven't done these questions yet, we're about to do it together. So you're worried about ascites, so you get those lab results and it's asking you, what is the cause of this patient's ascites? Is it heart failure, malignancy, or cirrhosis? And this is going to be a question where if you've answered heart failure, that's right, but we're about to go through it together. So initially, what is SAG? SAG is going to be your serum acidic albumin gradient. It's the difference between the albumin in the serum and the albumin in the acidic fluid. And a very easy way to remember this is that it goes in order. The S is the first letter, so you're going to start with the serum albumin. And on your test question, what you're going to get is a table that has a value for the serum albumin and a value for the acidic albumin. So you're going to have to subtract and determine whether that's high or low. So knowing that a high SAG gradient is more than 1.1 is going to be helpful on your exam. And the way that I think about SAG is there a cause for portal hypertension? Is there something causing backup, like heart failure or cirrhosis, which is causing elevated pressures in the portal system? So always think about portal hypertension if you're seeing a high SAG gradient. And now the acidic total protein is going to be the other variable that you have to keep in mind. So we mentioned you use the albumin for the SAG gradient. All of the acidic protein is going to be the other variable. So always look at these two variables if you're asked to determine the cause of ascites in a patient. And the way to think about total acidic protein is, do the hepatic sinusoids have normal permeability so things are able to move across? So if you think about it, for something like heart failure, you're going to have portal hypertension because you have backup, so you'll have a high SAG, but the liver itself, the hepatic sinusoids will have normal permeability, so the total acidic protein will be high. Meanwhile, for cirrhosis, you'll also have portal hypertension, but the hepatic sinusoids themselves are going to be fibrosed, so you won't have as good permeability, so the total acidic protein will be low. And feel free to go through the slide a couple of times, but it's helpful to think about the total acidic protein is the permeability of the hepatic sinusoids, while the SAG is going to be portal hypertension. So let's go back to this question here. So you've calculated out your SAG based on the serum and the acidic albumin, and 1.5, is that going to be high or low? So we go back and remember SAG of 1.1 or greater is high, so you know that this patient has portal hypertension. And now you look at the acidic total protein, and typically they'll give you a range for the acidic total protein, whether it's high or low, but in this case, we can see that it's high, so it's above 2.5. So remember, total acidic protein is going to be the permeability of your hepatic sinusoids. Because it's high, you know it's not cirrhosis, and so the answer for this one is going to be heart failure. And when would you be worried about SBP for a patient? So this is going to be if your PMNs are 250 or greater. And essentially for SBP, you have to be worried about the bacteria traveling across the intestinal wall and seeding the acidic fluid. So if you're choosing an antibiotic, you're going to want something that covers for gram negatives. And also remember on your exam that if you have a patient who has low acidic total protein, which is especially less than 1.5, there are increased risk for SBP. And remember again, low acidic total protein, think about cirrhosis for a patient who has low acidic total protein. Now, moving on to a slightly different question that's still within our liver topics. Let's say you have a 50-year-old female who has fatigue, pruritus, an elevated alk phos, and positive anti-mitochondrial antibodies. What are you thinking about for this patient? So this is going to be our PBC. And the positive anti-mitochondrial antibodies is both a good buzzword for your test question and relevant to real life. In the real clinical world, if a patient has a very elevated alk phos and a positive anti-mitochondrial antibody, that's actually going to be diagnostic, so you don't need a biopsy. And some key things to remember also is that the alk phos was elevated. We didn't say anything about the AST or the ALT in this question stem. And so again, expect a cholestatic liver injury pattern with an elevated alk phos. And how would you treat this patient? The answer for this one is going to be our ursodeoxycholic acid. And what is PBC associated with? So a couple of things they like to test you on. Hyperlipidemia and osteoporosis are two big associations, and autoimmune thyroid disease is also associated. And a similarly spelled condition that's also frequently tested, say you have a 40-year-old male with a history of UC who's presenting with pruritus, and he gets an MRCP, which is demonstrating a beads on a string pattern. So this is what they actually mean when you have a beads on a string pattern. Essentially, you're going to be having multifocal strictures and dilation, which is going to look like that beads on a string. And you can see here they drew some arrows for both those strictures and the dilations. And it's also important to note that PSC is going to have dilation both intra and extrahepatic. So PSC associated with IBD, primarily UC more than Crohn's disease. Also going to be a cholestatic pattern like we had with PBC. Remember those intra and extrahepatic strictures and dilations. And for this one, you're not going to be asked to pick an effective medical therapy. Effectively, you're monitoring for liver disease and seeing if they'll eventually need a transplant. And which two malignancies is this patient especially at risk for? So this is going to be your cholangiocarcinoma and colon cancer. And then which lab is used for cholangiocarcinoma surveillance? So this is going to be our CA19-9. And which two dermatologic conditions are associated, now switching a little bit over to IBD? So this is going to be pyoderma gangrenosum and erythema nodosum. So starting off with pyoderma gangrenosum, the peak generally is going to be actually 40 to 60 years with females more than males, but it is associated with IBD. It's going to be associated with a site that may have had a history of being injured at that location, and you'll have an expanding ulcer. It'll be very painful, and you'll have this purulent or a fibrinous base, and the treatment is going to be local or systemic steroids. Meanwhile, for erythema nodosum, this is actually not specific. It can be associated with many things other than IBD. This is actually inflammation of the fat underneath, so it's actually not, it's going to look quite different from the pyoderma gangrenosum, and it's going to be tender nodules that you see most commonly on the legs. And again, remembering it's inflammation of the subcutaneous fat, so you're not seeing that purulent base for erythema nodosum, and it can be associated with many different things, including strep infections, cocci, pregnancy, or oral contraceptives. And then just going through some buzzwords, they will have you select whether it's more likely to be ulcerative colitis or Crohn's based on these differences. In the real world, it can be a little less black or white, but on the test question, if you see these buzzwords, it's a very good likelihood that they're having you select one of the two options. So skip areas. Are you thinking more about Crohn's or UC? So this is going to be Crohn's. UC is going to be more contiguous and symmetric. What about transmural involvement? So this is again going to be Crohn's. UC is going to be more mucosal involvement. What about fistula formation? This is also going to be Crohn's. It's not as common for UC. And then finally, granuloma formation. This is again going to be Crohn's, so it's unlikely in UC. And then just an example of some complications. So say you have a 27-year-old male with a history of Crohn's disease who's presenting now with severe abdominal pain and vomiting. He looks like he has a fever, blood pressure is softer, and he's tachycardic, and you're noticing he has abdominal distension, decreased bowel sounds. What are you worried about for this patient? So this is going to be our small bowel obstruction, and you have increased risk of that with Crohn's disease. And what would you expect to see on CT for a patient with a small bowel obstruction? So the answer for this one is going to be a transition point with distended loops of small bowel. And what is the treatment for a small bowel obstruction? So this is going to be give him fluids. It looks like he needs some extra hydration, NG tube for decompression, and then potentially talking with our surgical colleagues to see whether he needs surgery. And then moving on to ulcerative colitis, just an example, you can have a 21-year-old male presenting with frequent bloody bowel movements, and a scope, you perform a diagnostic endoscopy which demonstrates mucosal rectal involvement. So how would you like to treat this patient? So the treatment is going to depend on the extent of involvement. Again, remembering that ulcerative colitis is going to be continuous. It's not going to be those skip lesions, so they'll always have rectal involvement. If it's just rectal involvement, you can actually give them a suppository. And if it's extending further up higher to, say, the sigmoid colon, you can give them mesalamine or glucocorticoid enemas. And on your test, you might see mesalamine suppository. You can also see it listed as a 5-ASA agent, and then sulfasalazine is going to be another option that you might see on your test.